you everyone for joining us today. It's our 9th annual Global Child Health Lecture Series, and it's our 4th day of the series. And it's my pleasure today to introduce Dr. Michelle Hsiang. She's a pediatric infectious disease physician and malaria epidemiologist. She's also newly the director of the Malaria Elimination initiative at UCSF. Very exciting. She's an associate professor in epidemiology, biostats, and pediatrics, and a Chan Zuckerberg BioHub investigator. Her research focuses on the development and evaluation of novel malaria diagnostics, surveillance, and drug-based interventions, including mass drug administration, to address the challenge of low-density infections that contribute to persistent transmission and disease in low-endemic settings, which is a little bit of what Dr. Ted Rule was talking about yesterday in terms of pediatric HIV. So there may be some overlaps there. And with that, Michelle, I'll hand it over to you.
Thanks, Teresa. And thank you to the organizers for having me and for folks for joining. I wear many hats. I feel like this project kind of brings together a lot of it. When I'm in the hospital, I use antimicrobials to treat individual patients. And in this project, we're using antimalarials to treat populations to help with malaria burden and get towards elimination. So I'm presenting on behalf of our entire team, and our collaborator, Jean-Louis Ndiaye, leads a team at University of Chess who was mainly leading the project, the field work. And also there's some others on this call that have been involved. So Xue Wu has supported the analysis. Let's see if anyone else is on the call from the team. There isn't, but we've got some MEI team members joining, which is great. So the objectives of this session are to become familiar with seasonal malaria chemoprevention as a strategy to decrease malaria burden in children, and to learn about this trial of mass drug administration versus SMC to decrease transmission and accelerate toward elimination. Just to review the life cycle, because it will become relevant for the design of the intervention. So malaria is an infection of the Plasmodium parasite that is caused by the transmission of the parasite from one human to another human through the bite of the Anopheles mosquito. And so an infected mosquito will while taking a blood meal, will inject the sporozoite stage, which will then travel to the liver for an incubation period of about a week to a month. And then the merozoite stage emerges and invades red blood cells. They replicate in the red cells and then burst, and then you get this cycle. And this is where you get the fevers from malaria. And then at some point, the merozoite stage turns into a gametocyte, sexual stage. And in order for this cycle to continue, the next mosquito that takes a blood meal needs to take up the gametocytes, and then fertilization happens in the gut, and then the sporozoite stage, is released from the salivary glands to the next human during, a next blood meal. Malaria still causes a large burden of disease, 250 million cases a year, and over 500,000 deaths. And 3/4 of these deaths are in children less than 5. And this is what drew me to malaria, is that it's very much a pediatric disease. Every 2 minutes, this equates to a child less than 5 years of age dying of malaria. But it's not all doom and gloom. The last WHO report, which comes out every year, has this nice figure which shows the cumulative number of cases and deaths averted through our efforts. And so since the last 20 years, we've had 2 billion cases averted and 12.5 million deaths averted. The US is a major contributor to these elimination efforts through your tax dollars and contributions to the President's Malaria Initiative and the Global Fund for AIDS, TB, and Malaria. So your tax dollars are going to good use in that way. So malaria is interesting in that if you get it, you may not always show symptoms. So you have a spectrum of clinical manifestations. You may be subclinical or asymptomatic. You may develop an uncomplicated malaria, which is sort of like the common cold in Africa. You just present with these nonspecific febrile illness, flu-like symptoms, and you often have malaria. And then a smaller proportion will progress to severe malaria that can be very severe, affecting multiple organ systems and leading to death, sometimes within a day or two of presentation. So where you fall on this spectrum really relies on immunity. So people who live in endemic areas are exposed frequently, and they can develop an immunity whereby they won't get as sick. Children and pregnant women are relatively immune naive, so they are more likely to develop severe symptoms. There's 5 different species of the parasite that affect humans, and falciparum is one that is more likely to cause you to have more severe malaria. And then how quickly you present, if you get the right treatment, if you take your treatment, these can affect how sick you are. Genetic polymorphisms and comorbidities can affect this. So there's sickle cell trait, which can be protective against severe malaria. Having sickle cell disease would predispose you to severe malaria. And malnutrition, other things can affect your risk for severe malaria. And so this map shows not just like the cases of malaria, but who's parasitemic. So they take in endemic areas of these cross-sectional surveys where they randomly select children 2 to 5. It depends, but often say in this less than 5 or sometimes all ages. But this group mapped out the risk of malaria in children 2 to 10 years of age. So this is not people who are sick. This is just any point in time who has parasites in their blood. And you can see that there's some areas that have almost 100% of kids are walking around with parasites in their blood. But fortunately, there's more blue on this map. And so light blue, the turquoise is more like 25%. When you're getting to the darker blue, closer to 1% of the population is parasitemic. And this is kind of what we're trying to address with our interventions that are sort of more targeting the communities. This project is focused on an intervention that has relevance to West and Central Africa and the Sahel. And this is an area, if some of you do other work in meningitis or something, this is the similar belt to where the bacterial meningitis is. And this is also the area where there's very seasonal transmission of malaria. So this shows the proportion of annual cases that occur within 5 consecutive months. And you can see in a lot of these places, including Senegal, which is where our project takes place, almost all of the cases happen in these 5 months. It's really remarkable. In the low season, you get very few cases, but there is a reservoir of parasites in people that's subclinical or asymptomatic that's maintaining transmission until the next season comes out. And the meningitis season, this usually happens in the malaria season after the rains come. The meningitis season will happen in the dry season. It's a different time. So to address malaria in these areas where there's seasonal transmission, there was this intervention that's really had a huge impact. It's called seasonal malaria chemoprevention for children. And what it is, it's the intermittent administration of a full treatment course of an antimalarial during the malaria season to prevent illness and deaths in children. And I didn't learn about this when I was in training. I finished my pediatric infectious disease fellowship in 2012. And it was only then that the WHO recommended this intervention for children 3 months to less than 5 years of age in areas of seasonal transmission. And this recommendation is recently expanded to 10 years of age. The drug of choice is sulfadoxine, pyrimethamine, amidiaquin. And the sulfadoxine and the pyrimethamine act synergistically to inhibit DHFR and DHPS, both of which are important for the parasite's folate biosynthesis pathway. It's a really remarkable drug in that you'll see later has a long half-life and a period of effective activity against the pathogen. We have very few drugs that you can just take a course and then it will be effective for a month. Amidiaquin inhibits heme polymerase, and that results in the accumulation of free heme, which is toxic to parasites. And so this drug, there's a lot of resistance to SP in other parts of Africa and the world, but for some reason in this area of the world, in Sahel, there's that resistance has not developed, so you can use this drug. It's long-acting, I mentioned, it's safe and effective, and it's affordable. And this is a dispersible version, which has now become available to facilitate administration in children. This is a review. It was like a case control study after SMC had already been rolled out. And you can see that across countries, after 28 days, after a month, so shown in blue, in red, the drug becomes less effective at preventing infection. Whereas within a month, it's highly effective to prevent a child from presenting with malaria. And that's why this drug is given monthly. And just to give you a sense of the scale of SMC, in 2014, shortly after this was recommended by WHO, 2.5 million kids in this region of Africa got SMC. And by last year, almost 50 million children got SMC. It's really remarkable. And this graph shows the number of cycles that the government uses per year. So usually it's been like 3, though now people have been expanding to 4 or 5 cycles a year, meaning that you get it every month for 4 months in a row. And you might see a variety even within a country. A lot of how many cycles they do depends on like really their budget and their resources. And if they expand to 10 years of age or not. Some countries, they're still within 5. Senegal wanted to expand to 10, but that meant that they couldn't do as many cycles. You know, they probably would like to do 5, but they're doing 3 or 4. At least last year, it may have changed. So just focusing in on our study site in Senegal, this is an area where there's seasonal transmission. Falciparum is the dominant species. They've had a lot of progress since 2000, where malaria has really declined. They're aiming for elimination by 2030. In the northern areas, there's much lower transmission. They've already shifted to these pre-elimination activities where they investigate every single case and what's going on around, and they might do something in response, like do a small focal drug administration or vector control in that area. In the southeast is where there's low to moderate to up to high transmission. In this area, they've been doing pretty much everything you can. So they do good case management. When you present for care, you can get tested and you can get a good treatment. They've rolled out this it's called Pecadom Plus, which is using a DESDOM. A DESDOM is the French word for a community health worker. And they do these weekly sweeps in the village, looking for people who have fever, and the community health workers trained to do testing and treatment. So it removes that barrier of health seeking. They're doing SMC in children under 10, bed nets, and then they also do intermittent preventative treatment for pregnant women, which is doing similar to SMC, but it's doing like monthly or treatment to a pregnant woman with SP. They're aiming for 5 treatment courses, but it sometimes depends. It's often time for when they come for their prenatal visits. This area has been a real challenge, and you can see that despite everything they're doing, cases have just really plateaued. And in order to get to elimination, it's really felt like we need to do something more. Vaccines are sort of available now. The RTSS, it doesn't have excellent efficacy. It's like 30 to 50%. But we're going to have better vaccines in the future. But for now, with the tools that we have, we think we can do more. And this is what this project is about. And what we need to target is this reservoir of infections that's low density and chronic. When transmission declines, a higher proportion of infections are actually low density. So this graph shows it's a systematic review. On the x-axis is what the prevalence is in the community by PCR, and the y-axis is the proportion that are detectable by microscopy. So you can see in a lower prevalent setting, lower transmission setting, a lower proportion of infections are detectable by microscopy. And that's thought to be because a higher proportion of infections are chronic. And this graph just shows chronicity of infection. So we now have some really great genotyping methods. And this work was on the right is work done by the Epicenter group of Brian Greenhouse and Isabel Barranca Rodriguez and Jessica Briggs, where they have kids they follow every month, and they get a blood sample. So they know about kind of asymptomatic parasitemia too, and they genotype the strains to see how long that infection lasts. In the past, we didn't really have that genotyping, those methods. And so you knew a kid was parasitemic, but they can be infected with multiple strains, and you don't know whether it's a new or old infection. But this is some really nice data that shows with a single strain, this is how long the infections last. So when you're younger, they don't last as long, but as you're older, they last weeks and months if you don't treat an infection. And so these people walking around with parasites in their blood are reservoirs for persistent transmission. So MDA is a strategy for elimination. And what it is it's administering an antimalarial to everybody in the population at approximately the same time at repeated intervals. And it's intended to be a time-limited intervention. So you don't do it forever. You kind of do it for a period of time to get to a goal. And in 2015, WHO recommended this for elimination in settings with very low transmission, and where they're doing everything else, good vector control, good case management, surveillance. But it has not been recommended for moderate high transmission settings. And this is concern that it wouldn't work, or there'd be potential that there would be a rebound. If you kept doing it, you would promote drug resistance. So it's not recommended right now. Before I go on, I can just pause. Are there any questions or comments? And we can make this, we're a small group, so we can make this informal. So feel free to just jump in with comments, questions, or put something in the chat. No, then I'll go on. So the objectives of the trial were to compare the impact of MDA versus SMC on malaria incidence at the village level during the implementation period and after MDA. The after MDA piece is being presented separately. What we're presenting today is in the first year of the trial. Another objective was to see if MDA could bring the incidence down to less than 5 per 1,000. So I didn't really give the details, but the WHO uses these criteria for moderate low. So this is kind of the level of incidence. It's in cases per 1,000 population that's happening in Senegal and the prevalence. The second objective was to see if we could get to less than 5 per 1,000, which was Senegal's criteria for getting to pre-elimination. We also looked at some secondary outcomes, prevalence, drug resistance, and also acceptability and cost effectiveness. This is the study site. It was the design was a cluster randomized controlled trial, which is where you don't randomize individuals, you randomize a cluster or a village because you're looking to measure community level impact. There's seasonal transmission here. Most of it happens in the second half of the year. They have an optimized malaria strategy where they're distributing good bed nets, and they're doing these weekly sweeps with the DESDMs or community health workers. And the transmission I mentioned is low to moderate. We had 60 villages that we randomized to SMC or MDA. So this is a map of where they are. The drug we used for MDA was a drug called dihydroartemisinin piperacin. It's an artemisinin-based combination therapy, which is the standard of care treatment for falciparum. You might be more familiar with Coartem, which we use in the United States, artemether lumefantrine. It's in the same family. But the nice thing about dihydroartemisinin piperacin is the piperacin is long-acting. It's shown to prevent malaria up to 6 weeks after a treatment course. So it's a nice drug to use for this type of an intervention. And then we added this single low-dose primaquine And primaquine is typically used to treat the hypnozoite stage, which is like a latent infection with the species Vivax or Valley. But if you use just a single dose, it's effective for gametocytes. That's the sexual stage of all the species. So it's because the ACT only treats the early stage gametocytes. And so adding on the single dose primaquine really gets at the transmission. So it's long acting. Another reason why we picked it is because it's not the first line anti-malarial medicine used for symptomatic malaria there they use Coartem. And I mentioned the gametocytes. And there has been limited evidence that MDA contributes to drug resistance, especially for using combination therapy, and we complete a treatment course. But as I mentioned, it's not intended to be a thing you do forever. It's intended to be a time-limited intervention. When we originally did some modeling work on this, it looked like you needed to get to do 3 years to really get down to those pre-elimination levels. The trial was originally planned for 2 years, but we didn't have enough funding, so we did 1 year, and that's a limitation of the study, but a reality of our funding situation. This was sorry, I forgot to mention earlier, this was a collaboration through Impact to Malaria, which was a consortium led by PSI, Population Services International, and funded through the President's Malaria Initiative. And we did this in collaboration with University of Chess and it was with UCSF and some other local partners in Senegal as well. So this is a study timeline. We started around the time of COVID with the scale up of the community health workers, the DESDEMs. They were in most villages, but not all of them. And we wanted to make sure that we had really optimized kind of the standard interventions. SMC, which is shown in green, was done 3 rounds in both arms, before we implemented the intervention. Bed net distribution, then we did a baseline survey. We repeated, we did a census to get our denominators. And then this is where we started our intervention with 3 rounds of MDA and then 3 rounds of SMC. We staggered them a bit just for logistics. And then also we did MDA 6 weeks apart, just because I mentioned that the DP can be effective up to 6 weeks. So we kind of wanted to stretch out our time of protection over the season. This is baseline survey results, and Pamela Gangar, who's a PEDS ID fellow, I don't know if she's on this call, she's working with Michelle Rowe, a postdoc in our group, as well as colleagues at Chess to put together these results, which should be coming out soon, of the baseline survey. But we sampled over 2,000 people. The prevalence by microscopy was 6.4%, and then by PCR is 19.2%. This is not surprising, kind of like with a lot of infections, COVID, which you might be familiar with. When you use PCR, you increase the detection of infection by 2-3+ fold. So not surprising. We had a certain criteria for how we would pick our villages. So there were a lot of villages in Tambacounda district, and we excluded ones that didn't meet that incidence criteria of being low to moderate transmission setting. We wanted to not have too much variation in size, so we had a size criteria. Some of them, maybe it wasn't going to be feasible for them to scale up the community health workers, and others cannot be geolocated. So we ended up with 111 that met the inclusion criteria, and then we randomly selected 60 from that. And then we also wanted to make sure that the villages had a buffer zone between them, so there wouldn't be like contamination and movement of people between the clusters. So then we randomized those 30 villages. And these are baseline characteristics comparing the villages. They were served by these health posts. And you can see we're fairly balanced on intervention versus control of, which health post they went to, and the presence of a DESDEM. We didn't get the DESDEMs up and running in 1/3 of the villages before we started. And so that is a limitation, but we did while we were in the trial, and at least it was balanced across arms. This is distance to the health post with similar across arms, population size. of the villages was similar, about 300 or so. The proportion of the population that's less than 10 was similar across arms, and the baseline prevalence. This is some other factors, age, whether they spent last night, a night in the past 2 weeks away, a measure of like their travel. Bed net coverage was very high. If the children that were less than 10 received SMC, and you can see like almost 80% received SMC, almost about 70% completed all 3 cycles in the year before the trial. So this shows the initial kind of coverage of the 30 villages. We did 3. We refer to a cycle for SMC and a round for MDA. But of the 3, this one, the population is larger because this was all ages, and this is just those under 10. But this is the numbers that received, were screened or received 1, 2, or 3 doses. So we treated 6,000-7,000 people per round with MDA, and over 3,000 every round, every cycle for SMC. These are some pictures of the work in the field. It was a house-to-house delivery, directly observed therapy, and it's a campaign style. So before you go out, there's like a lot of sensitization that's done with commercials and radio ads, and notifying the community through the community health workers and leaders to remind them to be home this day when we're going to be administering SMC. Let's see. I don't want to miss Jean-Louis. Is he on the call? Okay. This is some more pictures from the campaign and our meetings. And this is a image of a figure of coverage. So on the x-axis, we have the round or cycle, and then the y, we have coverage. WHO recommends greater than 80% coverage of the eligible population. So we actually didn't target pregnant women. So pregnant women is not in the denominator here. But we got about 80% coverage with MDA, and much better with SMC. I think some of the challenges of getting better coverage, in MDA versus SMC is MDA, you're aiming for the adults, and the adults, they have work to do or travels to make, and so it's harder to get them. Also, not a lot, but some might not want medication. We didn't get that. We had 1 to 2% refusals. We also excluded people if they were ill that day, and sometimes they would say they were ill, I think, if they didn't want medication. This is the crude coverage. So this is the entire population as a denominator. So the denominator includes like pregnant women and such. But you can see still like our number 1 reason for missing drugs was not being there. So that may be on purpose, or they just weren't around. But we still got pretty good coverage, I'd say 70% of the community for MDA. This is our first figure on the results of the trial. So this graph shows the first row is the primary outcome of incidence in all ages, and then we have the number of cases per 1,000 population, before and after, and then the incident rate ratio that we got when you compared intervention to control, and then we just directly put here the effect estimate, which is 1 minus the ratio of the IRs. So in all ages, and this is adjusted and unadjusted. Adjusted takes into account those things like DESDUM coverage or bed nets, all the baseline factors. And even in the adjusted analysis, we saw that MDA versus SMC decreased incidence by 55%. And this was our confidence intervals. It didn't cross 0, so or 1. We feel like we are pretty confident with this result. if you do the analysis stratified by age, you see more of an effect, 57% in the older 10. And that makes sense because in the SMC arm, they're not getting drugs. But we still saw an effect in the less than 10, which was really interesting, suggesting that the dihydroarsenite paraquine and primaquine combination might be more effective for treating parasitemia or preventing malaria in these young kids than the drug we use in SMC. Or it may be just that because we're doing this community level drug, we're seeing an impact on transmission. So there's just less malaria around for the kids to get infected. These are some subgroup analyses with less than 5. We saw a trend, but it wasn't statistically significant. And then we looked at if you had a DESDEM at baseline versus not, and there was still an effect. And then let's see, by stratified by transmission intensity, we actually saw more of an effect in the moderate transmission settings and not the low. And it may not be that it doesn't work in low. It may be that the effect size is 20%. Maybe you just see less of an effect in lower transmission settings, and we weren't powered to see that effect in the lower transmission settings. But it looks like it works in this moderate transmission setting. These are just some visuals of the difference in the difference. So you're comparing MDA in green to SMC before and after, and you can see that we saw more of a reduction in MDA. And then stratified by age, this is the greater than 10 and the less than 10. And I mentioned we saw the greater effect in the more than 10. We also did an N-line survey, which is like we did a cross-sectional survey, just like we did in the baseline to measure prevalence of infection. We targeted a little over 2,000 people. And these are the results. And the trends kind of follow what we found with the incidence. So in all ages, if you use microscopy, our effect was 61, 62%. By PCR, it was lower, 50%, almost 50%. I'm not sure if that's what that means. It may just be that, these confidence intervals cross. So maybe the effect is similar, or it may mean that the MDA is more effective for eliminating like clinical higher level infection rather than lower level infection. Let's see, and then similar trends. So for the prevalence, actually, it's opposite. So we saw a larger effect in the younger age group than the older age group. And our main hypothesis on this is that in the older ages, we got less coverage in our survey. They weren't home as much, the adults. And so we're wondering if it's just that we, didn't get all the adults, and so that were parasitemic, so we couldn't, we weren't able to measure that effect as well in the older 10 groups. That's a hypothesis, but it may also mean something about there may be a difference of measurement in what prevalence and incidence reflects. That we're just putting these results together in the paper, so our team is sort of talking about this right now. If anyone has any ideas, please jump in. This is just some visuals of the impact on prevalence by microscopy and PCR. And then we looked at markers of drug resistance for SP and the artemisinins, and we didn't see any difference at baseline and end-line in the prevalence of known markers of drug resistance. So it's good. And then we did passive pharmacovigilance, which meant when people had an adverse event, they would alert a community health worker or somebody in the study. And we had less than 1% AEs in both arms. No SAEs in either arm. And anybody who had an AE recovered without sequelae. They were fever, nausea, vomiting, headache, abdominal pain. By active pharmacovigilance, that's where we randomly selected some households, and we went on day 4 to ask if you had symptoms. And we went to a certain household, and I think we picked 3 people from different age groups in that household and asked them if they had symptoms. We got much higher, more than 1%. So in round 1, 16, 20%, less as the rounds went on. I think this is because if you ask people, then they're going to tell you what kind of symptoms they have. But the important thing is that they were pretty similar across the arms, and that they decreased as the rounds went on, and that there were no SAEs. So we feel like the intervention was safe. So overall, we found that MDA decreased malaria incidence by 53% and prevalence by 62% compared to SMC. We saw more of an effect in the older age groups for incidence. And that made sense. With the prevalence, why we're seeing more of an effect in the younger, we're still thinking through, but we think it might be an artifact of our coverage in the survey. Absences were the main reason for non-coverage, but we still got greater than 80% distributional coverage, which is recommended by WHO, and it was safe and well accepted. We had few refusals. So we conclude that in this setting where there's seasonal transmission and optimized control, including SMC, MDA should be considered as a strategy to accelerate toward elimination. There were some limitations of this study. So one is that we depended on RDT for that calculation of incidence. And you can get false positives with RDT because, like the COVID test, it targets the antigen, which can persist for several weeks. You can be positive even after you've cleared your infection or been treated. But this probably would have just biased towards a null. I mentioned the DESDUM roll-up, and this may have affected the effect estimates, but if anything, it would have biased towards the null. We didn't reach that secondary goal of getting incidence down below 5%, 5 per 1,000. And I don't think anyone expected we would, because it was just 1 year. And when we had done that modeling exercise I mentioned before, it would have taken 3 years to get there. You could maybe get there faster if you did more than 3 rounds in 1 year. So that's an idea. And we only looked at short-term impact. So we have a follow-on study looking at sustained impact or rebound. The strengths, there was a large sample size. We had rigorous monitoring of safety outcomes at the active and passive. We got high coverage. We saw a large effect size in spite of there being optimized interventions in the control arm. And this adds to the literature for MDA as a potential intervention in a moderate transmission setting to reduce transmission. There's only 2 other cluster randomized controlled trials of MDA in moderate transmission settings that the WHO has reviewed and taken into consideration. There was one from Zambia, and that's an area where it's more perennial, and they use dihydroartemisin paraquat compared to no MDA. They saw no effect. It might be because they scaled up indoor residual spraying at the time. That's where you spray the inside of a house with an insecticide, the walls, to repel and kill mosquitoes. And it may have been that it was just the IRS was so effective that MDA on top of that wasn't enough to be effective. But in the Gambia, which it sits within Senegal, they did a similar trial with DP, and they use ivermectin, which is a different drug than permaquin, but it also it has a transmission reducing effect. And they saw a bigger effect than we did, 79 and 70%. And they did 2 years. They had the funding to do 2 years. So we're thinking that our trial with the Gambia trial could inform a new recommendation to do this that it's okay to do this in a moderate transmission setting to rapidly decrease transmission where you have seasonal malaria. So next steps, we have this analysis of the follow-up year. We're expecting some, I'm not expecting a sustained level of impact, obviously, if we weren't doing MDA the second year, but it'll be interesting to see where we saw kind of more of a sustained impact and perhaps why. We would like to do an analysis on optimal timing and rounds and years for MDA. This would be a modeling exercise. We have some serology measures from our cross-sectional surveys that we're looking at. We have a cost effectiveness analysis and a qualitative study on acceptability as well. That's all in process. And MDA is already planned for implementation in Senegal. They're taking it on in a few districts, other districts now. We hope that this will inform some WHO policy I mentioned. And I think just broader next steps is we have to think about, what mix of interventions make sense when and where. We're going to have vaccines soon. when do you use something versus something else versus a combination, and when do you transition, stop, or start things, I think are big questions. This was a big team that put this project together, and PNLP is the national program. The regional office in Tamba, they were really supportive. This would not have happened without kind of this project actually arose from the Senegal PNLP, the malaria program. They asked the President's Malaria Initiative for support to do this project. University of Chess, we're part of the Impact Malaria team with PSI. London School, CDC was involved, UCAD, another university in Senegal, and CGAS as well. So thank you for your time. And yeah, thanks to the regional and district health offices and the entire team that helped support this trial. Happy to take questions or comments. Thank you.
Thanks so much, Michelle. If anyone wants to come off mute, go ahead. You can also raise your hand or put questions in the chat if you're not in a place where you can speak. But I wondered if you wouldn't mind just commenting on, there's been some press on the vaccine, and since you mentioned it at the end, kind of where you see, I know it's not as effective as we would hope it to be at this point, but kind of where you see this field going in terms of malaria elimination in the next 5 to 10 years, given where we are.
Yeah. Well, there's already been a trial where they combined IPTI. We have all these acronyms. That's intermittent preventative treatment for infants. It's basically like SMC, but you give it to infants. They combined it with, because it target SMC. Well, we started at 3 months, but in some places they don't start till later. But they did a trial where IPTI plus RTSS compared to IPTI alone was more effective. And there are trials ongoing right now of SMC plus RTSS. And I'm sure there will be trials of R21 as well, the new vaccine. I think a lot of it comes down to, our fund, like given the current economic situation, funds for malaria are not going to increase. That's, I think we know that. And how do we do things smarter with the funds that we have is a big question. So yeah, if you had all the funds in the world, you could combine SMC with vaccine or MDA with vaccine. But that would limit, you wouldn't have funds to do other things. And maybe in an elimination setting, it doesn't make sense to do that because there's fewer people with malaria and you want to do more of your efforts in the control setting. So how do you get the most bang for your buck? I don't know the answer yet to that. I think we need to do a lot of work on that. Yeah. I don't know if we have others from the Malaria Elimination Initiative on. Does anyone have any thoughts on that? Like combination interventions and how we would decide to deploy those? It really takes like a whole picture approach, which people don't do. A lot of researchers, we answer a very specific question in a very specific setting. But then for a program to make a decision, they need kind of a more big picture approach to think about things, make decisions.
Thanks, Michelle. That was really exciting stuff, actually. That was a nice talk. I just had a question about this finding that you have in bold at the bottom of this slide, and maybe I just missed this from the presentation. But in the arm that had MDA, were they also doing SMC?
No.
Okay.
Yeah, I should have clarified that. They were not. So it was like that statement, I think I mean like the reason I put that statement is because, well, you could consider doing it in a setting where you're not even doing SMC. So maybe I should revise this statement. We're still drafting the papers, but what I meant is in this setting, they were doing a SMC, so they had the infrastructure to deploy a house-to-house administration of drugs. And they had a community that was used to people coming and delivering drugs. So from an operational standpoint, I think it makes sense, but also from an effectiveness standpoint, like on top of SMC, like let's say you did SMC this year, next year, if you did MDA, you probably will see more of an effect than if you just continued SMC, is my point.
I see. So that statement has more to do with potentially
Yeah.
the cost effectiveness, maybe, because if you already have the infrastructure set up for SMC, it might be easier to just transition to MDA.
Right.
Versus...
We might want to, I think this probably should be like an optimized control. But SMC versus, and I don't know, because we had a lot of back and forth about this. Like some people were like, this trial was MDA versus SMC. And then other people were like, no, the trial was not MDA versus SMC. The trial was MDA in a setting of optimized control, like compared to optimized control compared to optimized control.
Okay.
But I think, yeah. I think the seasonal bit is interesting. Like, why I think you could see more of an effect in a setting where you have seasonal transmission, because that's where you're seeing most of the cases. So you're just by virtue of doing the intervention during the season, you're going to decrease cases. And in an area of perennial transmission, it would be hard to do this all year. I guess you can focus on the high season period to do it. But I think that was in our favor. I think it's going to potentially work more in a setting with seasonal transmission.
Michelle, for those looking to get involved in malaria elimination at UCSF, are there opportunities for trainees of various levels? And what would those look like?
I mean, absolutely. We have our team is about 35 people, half of which are based in San Francisco and half in other places in the US or abroad. And we do a combination of research and technical assistance and also advocacy. So there's a variety of work that we do. I'm more on the research side. Eddie here leads our entomology work. He's an entomologist. We have actually a handful of entomologists. And, because we can't really just focus on the parasite. This is about the vector and the parasite and the host. And we have a bunch of projects going on, which I don't have time to get into, but all around supporting countries in elimination. A lot of it's around surveillance, drug-based approaches, innovative vector control methods that target residual transmission. We're also doing some work on molecular surveillance. And we have an arm that does work on advocacy, financing, and sustainability, like helping programs, basically making sure they have the funding to do their work, to advocate for those funds in country. Just you come talk to me, or you can visit our website. It's Shrinking the Malaria Map. You can also find it within the IGHS website as well. I would just have maybe others can introduce themselves from our team. Like, since we have a little bit of time, if you wouldn't mind introducing yourselves and what you do, what your role is on MEI. Can I start with you, Eddie?
Yeah, sure. So as Michelle said, I'm an entomologist and I'm a senior program manager for the vector control and entomological surveillance portfolio of work at MEI.
Thanks, Eddie. Gretchen?
Hi, morning. I am a senior research manager at MEI. I do kind of a grab bag of things. I do a lot of writing and I'm a technical writer with our PMI consortium, the same consortium that this Senegal trial falls under. And I also currently, my biggest project is adapting our high-risk population guide for malaria use, which is how we've been using it. We're adapting it for use with neglected tropical diseases. And right now we've got a small assessment going on in Uganda to test out this guide and see how applicable it is in this different environment. So it's just a snapshot of what I do. Thanks, Michelle.
Thanks, Gretchen. Xue?
Hi everyone. My name is Xue. I'm the data analyst in MEI working with Michelle. We focus on the Senegal and some other projects to eliminate the malaria. Thank you.
Thanks, Shreya. Pamela?
Hi, good morning, everyone. I am a pediatric infectious disease fellow. As part of my fellowship, I'm doing 2 years of research with MEI. I'm working on the baseline prevalence for this study in Senegal, and then I'm also working on a project in Tanzania.
Thanks, Pamela. And Jessica?
Hi, my name is Jessica, and I'm a summer intern with Flame, which is one of our other projects, and I've mainly just been helping Xue with entering data and helping with that.
And I think that's it.
That's an amazing team. I put the link to shrinking the malaria map in the chat for people to see. And I also put an evaluation link for this session. For those who've attended, we do collect the evaluations and we look at them and then incorporate your feedback year to year. It's super short. It's like 2 or 3 questions. So if you don't mind just taking a moment and filling that out, we really appreciate it. And then I wonder, Michelle, do you would you feel comfortable putting your email in the chat?
Yeah.
And then as if anyone else has questions, please just raise your hand. I was wondering, I kind of know your career path, but could you spend just a couple of minutes kind of explaining or kind of the arc of your trajectory?
So I went into pediatrics with an interest in global health, but I didn't really know where to start. And I was in a global health track as a resident. Oh, sorry, in medical school, I started doing some work. I did a international health track then, and I think I did a tropical medicine course, and did some small projects here and there, but nothing major. And then during residency, I did a global health track again, and I don't know, I was interested in infectious diseases and something in China. I'm Chinese, and I came across a group doing schisto work in Berkeley. And also they were working in low transmission settings on schisto elimination. So there were a lot of questions around surveillance and people who are asymptomatic. And then I had an article written about a small project that I did, and Richard Feacham, who founded our group, he used to be the founding executive director of the Global Funds for AIDS, TB, and Malaria, and he came to UCSF to start a program on malaria elimination with a startup grant from the Gates Foundation. And he just read that article, or his wife did, and he wanted to meet and just said, do you want to work on another parasitic infection in China? And I was like, okay. So I joined, and I did a lot of learning from there because I was trained as a physician, and I didn't really know that much about public health or global health, but I kind of learned it along the way. I did a master's in epi through the London School later on. I did an ID fellowship, and I worked with Richard in Asia initially, and learned a lot about the malaria landscape there and what was needed to support elimination efforts there. And then gradually that transitioned into because I kind of understood kind of the landscape, then I saw what some of the challenging questions are. And I just realized I really wanted to do that kind of research. And so, but research that was relevant to support countries in elimination. So that's how I got on this research track. And then stayed with MEI, went away to UT Southwestern for a little bit, but still stayed connected to MEI, and have been able to stay funded through like grant funding we have through like foundations like the Gates Foundation. We've partnered with US based funding opportunities like through USAID, PMI. And then I also apply for grants through NIH for some of the research work. So hopefully that answers your question.
Yeah, it's just amazing. And we've seen some common themes where people, it's kind of like a meandering path where people end up. And a lot of it seems to be, there is some luck involved, but also like putting yourself out there and then like doing things and knowing that one thing leads to another. And it might be a course, like a directional change, but taking the opportunities.
Yeah, I think the best advice that I got was to just, is that your mentorship is the most important, not necessarily the project. I think some people think I want to do this, but early on in your training, you're not really going to get that. It's not so much about the project. It's about kind of learning how to do things. And so I think I tried to pick good mentors, even if I wasn't interested in that project. And then also taking a risk early on is a little bit easier to take risks, and try something out, and not be afraid to do something that you think you can't do, because I've done a lot of things that I didn't think I would do, like some of these kind of regional collaborations, or like economic analyses. You kind of learn along the way and you collaborate with people. That's really the key to doing things.
Any other questions from the group?
I was wondering if first, thank you so much for being here and giving this fantastic talk. I was wondering if you could speak to how you think climate change could impact kind of like frequency and duration of SMC and MDA and just like elimination efforts in the future.
Well, I think that, there's a lot of talk of that, I think, because we have a few local cases in the United States. I don't know if climate change is contributing to that per se. We've always had, not always, the last local outbreak was in 2003, but that seems kind of recent to me. But every once in a while we still have Anopheles mosquitoes. People will bring in malaria because there's a lot of travel, and so every once in a while you get a little local outbreak. But people in the US generally don't live outdoors and can seek care when they're sick and get treated. So it's not sustained. But in areas where malaria is endemic, I do think climate change can impact can impact malaria. If anything, it changes, like it can change the amount of malaria we get, but it can also change like the predictability of things. Like one thing we have a lot of trouble with in malaria is like a lot of our interventions are around the season. We like we distribute bed nets, we do spraying before the season. This MDA intervention, this SMC is during the season. And it's hard to plan for that when you may not have as much consistency with the weather. I feel like maybe here you go. I was going to say Eddie should probably answer this as an entomologist. What are his thoughts? I'm sure he has an entomology perspective, but right, in the most immediate sense, like it seems like dengue is probably more an obvious issue right now related to climate change. We're seeing it in urban areas, but we're also seeing urban malaria too right now. We have a project on urban malaria in Senegal, which has become an issue. So there's a lot more talk of it in dengue, but it's definitely relevant in the malaria world too. But I don't have a clear answer for you, except that it is going to be an issue.
Thank you.
And we have to be thinking about it and prepare for it.
Thank you very much for your time, Michelle, and it was great that your team could join too. Fantastic. Really appreciate it. We will rejoin